Good evening, and welcome to a journey into one of humanity's darkest chapters. A time when the phrase, "this will hurt more than it helps," wasn't a joke, but a grim medical reality. Tonight, we're stepping into the blood-soaked operating theaters of centuries past, where surgeons wielded bone saws like butchers, patients screamed themselves unconscious, and death was often considered a mercy compared to the agony of survival. This is the horrific reality of surgery before anesthesia. A world where speed mattered more than skill, where infection was inevitable, and where the surgeon's greatest qualification wasn't their medical knowledge, but their ability to ignore human screaming. Before we make the first incision into this bloody chapter of history, leave a comment telling us which country you're watching from and what time it is right now. Let's see who's brave enough to witness the horrors of pre-modern surgery across the globe. And whether you're watching this in the safety of daylight or the appropriately dark hours of night, imagine, if you will, waking up tomorrow morning with a gangrenous leg. In today's world, you'd be rushed to a sterile operating room, put under general anesthesia, and wake up hours later with your limb either saved or cleanly amputated, your pain managed with precision-dosed medications. But if you had been born just 2 centuries ago, your reality would have been incomparably different. You would have been strapped to a wooden table, surrounded by men in blood-stained aprons who had likely performed their last surgery with the same unwashed tools they were about to use on you. Your last coherent memory would have been the sound of a bone saw grinding through your femur while you screamed yourself hoarse, praying for unconsciousness that might never come. This was the reality of surgery for thousands of years of human history. From ancient Mesopotamia to the battlefields of the American Civil War, surgical procedures were exercises in controlled torture, where success was measured not by patient comfort or even survival rates, but by how quickly a surgeon could complete their work before their patient died from shock, blood loss, or sheer agony. The very concept of painless surgery was considered not just impossible, but potentially immoral. Pain, according to the prevailing wisdom of centuries past, was a natural and necessary part of healing. Some religious authorities even argued that attempting to eliminate surgical pain was tantamount to interfering with divine will. After all, hadn't women been condemned to suffer in childbirth since Eve's transgression in Eden? Wasn't suffering a path to spiritual purification? These beliefs weren't merely philosophical curiosities, they were genuine obstacles to medical progress that condemned countless millions to unnecessary agony. To understand just how nightmarish pre-anesthesia surgery truly was, we need to travel back to the surgical theaters of the 18th and early 19th centuries. Picture the scene: a large, circular amphitheater packed with medical students, curious physicians, and sometimes even paying members of the public, who had come to witness what was essentially a public spectacle of human suffering. The patient, often a poor soul from the charity wards who had no choice in the matter, would be carried in on a stretcher, already weakened by whatever condition necessitated the surgery. The preparation was minimal and brutal in its simplicity. The patient might be given a leather strap to bite down on, a wooden stick to clamp between their teeth, or, if they were particularly fortunate, a small amount of laudanum or alcohol to dull their senses slightly. More often than not, however, they faced their ordeal completely sober and terrifyingly aware of what was about to happen to them. The surgical instruments of the era were a testament to both human ingenuity and barbarism. Bone saws that looked more like carpentry tools than medical instruments, amputation knives with blades as long as a man's forearm, forceps designed to grip and tear rather than delicately manipulate tissue, cauterizing irons heated in open flames, to sear shut bleeding vessels. These tools were rarely, if ever, cleaned between patients, and the concept of sterilization was still decades away from mainstream medical practice. The surgeons themselves were a breed apart from modern physicians. Speed was their most prized skill, far more valuable than anatomical knowledge or surgical precision. The legendary Robert Liston, known as the fastest knife in the West End, could amputate a leg in under 3 minutes. This wasn't just showing off, it was a matter of life and death. The longer a patient remained conscious during surgery, the greater their chance of dying from shock. The human body can only endure so much trauma before it simply shuts down, and pre-anesthesia surgeons were in a constant race against their patient's pain threshold and cardiovascular system. But Liston's speed came with its own horrific costs. In his most infamous operation, he amputated a patient's leg so quickly that he also accidentally cut off 2 of his assistant's fingers and slashed through the coat of a surgical observer. The patient and the assistant both later died of gangrene, and the observer, convinced he had been fatally wounded, died of shock on the spot. It remains the only surgery in history with a 300% mortality rate. Grim testament to the chaos and desperation that characterized pre-anesthesia surgery. The psychological preparation for surgery was perhaps as important as the physical preparation, though no less barbaric. Patients were encouraged to pray, make their peace with God, and settle their worldly affairs before going under the knife. This wasn't mere spiritual comfort, it was practical advice. Surgical mortality rates in the pre-anesthesia era ranged from 30 to 80%, depending on the procedure and the skill of the surgeon. Death was not just a possibility, it was a probability. Those who did survive the initial trauma of surgery faced an equally daunting challenge: infection. The understanding of germ theory was still decades away, and the concept of sterile technique was unknown. Surgeons operated in their street clothes, often in the same blood-stained aprons they had worn for previous operations. They would move directly from dissecting corpses in the anatomy lab to performing surgery on living patients without so much as washing their hands. In fact, a surgeon's apron that was thoroughly stained with blood and other bodily fluids was considered a mark of experience and competence. The more gore, the more skilled the surgeon. Post-surgical infection was so common that it had its own terminology. Hospital gangrene was a specific type of aggressive, spreading infection that could consume entire limbs or even kill patients within days. Laudable pus was considered a positive sign of healing, as surgeons had noticed that patients who developed thick, white pus at their surgical sites often survived, while those whose wounds remained dry or developed thin, foul-smelling discharge frequently died. What they didn't understand was that laudable pus indicated a successful immune response, while the other types of drainage suggested more serious systemic infections. The types of surgeries performed in this era were necessarily limited by what the human body could endure while conscious. Amputations were by far the most common major surgical procedure, often performed on soldiers who had suffered battlefield injuries or civilians whose limbs had become gangrenous due to injury or disease. The technique was brutally straightforward. The surgeon would make a circular incision through the skin and muscle, saw through the bone as quickly as possible, and then pull the skin over the stump before sewing it closed. The entire procedure, if performed by a skilled surgeon, could be completed in minutes, but even simple amputations could go horrifically wrong. Patients sometimes died from the shock of the initial incision before the surgeon could even reach the bone. Others succumbed to blood loss when major vessels weren't properly sealed. Many who survived the surgery itself died days or weeks later from infection, or from what we now know was pulmonary embolism, blood clots that formed at the surgical site and traveled to the lungs. Trepanation, the practice of drilling or cutting holes in the skull, was another common surgical procedure that predated anesthesia by thousands of years. Archaeological evidence suggests that trepanation was performed as early as 6500 BCE, making it one of humanity's oldest surgical procedures. The reasons for trepanation varied widely across cultures and time periods. Sometimes it was performed to relieve pressure from head injuries, sometimes to treat epilepsy or mental illness, and sometimes for spiritual or ritualistic purposes. The process of trepanation without anesthesia was particularly nightmarish. The patient would be held down, while the surgeon used a trepana specialized boring tool to slowly drill through the skull. The procedure could take hours, as the surgeon had to work carefully to avoid damaging the brain beneath. Patients often remained conscious throughout the entire ordeal, experiencing not just the pain of having their skull opened, but also the terrifying sensation of hearing and feeling the bone being ground away. Remarkably, many patients survived trepanation, as evidenced by archaeological finds showing healed trepanation sites. This suggests that ancient surgeons had developed remarkably sophisticated techniques for this procedure, despite lacking any form of anesthesia. However, the psychological trauma must have been immense, and many patients likely suffered from what we would now recognize as severe post-traumatic stress disorder, lithotomy. The surgical removal of bladder stones was another procedure that demonstrated both the desperation of patients and the limited options available to pre-anesthesia surgeons. Bladder stones, caused by concentrated minerals in the urine, can cause excruciating pain and make urination extremely difficult or impossible. In an era before effective medical treatment for this condition, surgery was often the only option. To prevent death from urinary retention and subsequent kidney failure, the lithotomy procedure was performed with the patient lying on their back with their legs raised and spread apart. The surgeon would insert a probe into the bladder through the urethra to locate the stone, then make an incision in the perineum, the area between the genitals and anus, to access the bladder from below, using specialized forceps. The surgeon would then attempt to grasp and extract the stone through this external incision. The entire procedure was performed without anesthesia, and patients often had to be physically restrained to prevent them from moving during the operation. The pain was described as being beyond human endurance, and many patients died from shock during the procedure. Those who survived faced significant risks of infection, incontinence, and sexual dysfunction due to damage to surrounding tissues. Samuel Pepys, the famous English diarist, underwent lithotomy in 1658 and wrote extensively about his experience. He described the operation as cutting of the stone and noted that he was awake and aware throughout the entire procedure. Despite the horrific nature of the surgery, Pepys survived and actually celebrated the anniversary of his operation for the rest of his life. So grateful was he to be alive and free from the agony of bladder stones. The treatment of breast cancer in the pre-anesthesia era provides another stark example of the limitations and horrors of surgery without pain relief. Mastectomies were performed as early as the 1st century CE, but the procedure remained largely unchanged for nearly 2,000 years. The patient would be strapped to a table or held down by assistants while the surgeon used a knife to cut away the entire breast, often along with underlying muscle and lymph nodes. Fanny Burney, the English novelist, underwent a mastectomy in 1811 and left a detailed account of her experience that remains one of the most harrowing descriptions of pre-anesthesia surgery ever written. She described how 7 men held her down while the surgeon commenced a soft, sawing motion with his knife. The operation took 20 minutes, during which Bernie remained conscious and aware of every cut. She wrote that she began a scream that lasted unintermittingly during the whole time of the incision, and that she almost marveled that it rings not in my ears still. Bernie's account is particularly valuable because it provides insight into the psychological as well as physical trauma of pre-anesthesia surgery. She described feeling that she was being in the hands of beings who were performing some horrible experiment upon me for which I was not prepared. This sense of helplessness and violation was common among surgical patients of the era, and many never fully recovered from the psychological trauma, even if they survived the physical ordeal. The challenge of performing surgery on conscious, struggling patients led to the development of various restraint techniques and devices. Surgical tables were equipped with leather straps and iron brackets to hold patients immobile. Some operating theaters employed professional holders, men whose sole job was to physically restrain patients during surgery. These holders had to be strong enough to keep a patient from moving even when experiencing extreme pain, but also skilled enough to maintain their grip without interfering with the surgeon's work. The role of the surgical assistant was equally demanding and traumatic. Assistants had to help hold patients down, hand instruments to the surgeon, and sometimes even help apply pressure to bleeding vessels or assist with retracting tissues. Many assistants, particularly medical students, fainted during their first surgical observations, or became physically ill from the combination of blood, screaming, and human suffering they witnessed. The speed required for successful pre-anesthesia surgery created a unique culture among surgeons. They developed specialized techniques for rapid amputation, including specific ways of holding knives for maximum cutting efficiency and methods for quickly tying off blood vessels. Some surgeons practiced on cadavers to improve their speed, while others developed their own specialized instruments, designed for rapid cutting and bone removal. This emphasis on speed sometimes led to tragic mistakes. Surgeries were performed so quickly that surgeons occasionally cut through the wrong tissues, severed important blood vessels, or left surgical instruments inside patients. The pressure to operate quickly also meant that there was little time for careful anatomical dissection or precise surgical technique. Surgeons had to make rapid decisions based on limited visual information, often working in poorly lit conditions with inadequate exposure of the surgical site. The evolution of surgical pain management before anesthesia reveals humanity's desperate attempts to address this fundamental problem. Alcohol was probably the most commonly used pain reliever, though its effectiveness was limited and its side effects could be dangerous. Patients were sometimes given enough alcohol to become unconscious, but this carried significant risks of alcohol poisoning, aspiration, and respiratory depression. Opium and its derivatives were also used when available, but these substances were expensive and not always effective for surgical pain. The dosing was largely guesswork, and the risk of overdose was significant. Some patients who received opium before surgery never woke up, while others found that it provided insufficient pain relief for major surgical procedures. Various herbal preparations were tried across different cultures, with mixed results. Mandrake, root henbane, and other plants containing natural anesthetics were sometimes used, but their potency was unpredictable and their side effects could be severe. Some preparations caused hallucinations, others caused dangerous drops in blood pressure or heart rate. and still others simply didn't work at all. Physical methods of pain control were equally primitive and often ineffective. Pressure points were pressed to try to block nerve transmission, though this technique was poorly understood and rarely successful for major surgery. Ice was sometimes applied to numb surgical sites, but this was only effective for very superficial procedures. Some surgeons attempted to use compression techniques to temporarily cut off blood flow and nerve transmission to surgical sites, but this often caused more problems than it solved. The psychological preparation of patients often involved elaborate rituals designed to induce a trance-like state, or at least provide some mental distraction from the impending ordeal. Some cultures incorporated religious ceremonies, chanting, or meditation techniques into pre-surgical preparation. While these methods might have provided some psychological comfort, they did little to address the fundamental problem of surgical pain. The development of surgical theaters as public spectacles added another layer of horror to pre-anesthesia surgery. These theaters were designed like Roman amphitheaters, with rising tiers of seats that allowed large audiences to observe surgical procedures. The primary purpose was medical education, as surgical techniques were learned primarily through observation rather than formal instruction. However, these public surgeries also served as entertainment for some segments of society. Wealthy individuals sometimes paid to observe surgical procedures as a form of morbid curiosity. The atmosphere was often more like that of a gladiatorial contest than a medical procedure, with audiences cheering successful operations and at surgical failures. For the patients, being operated on in front of large audiences added humiliation and psychological trauma to their physical suffering. They were often charity cases who had no choice but to submit to public surgery in exchange for medical care. The knowledge that their pain and suffering was being observed by dozens or even hundreds of spectators must have intensified their psychological distress significantly. The surgeons, too, were affected by performing in these public arenas. The pressure to perform successfully in front of large audiences sometimes led to rushed procedures or unnecessary surgical showmanship. Some surgeons developed reputations as much for their theatrical abilities as for their medical skills. They would engage with the audience during procedures, explaining their techniques or making jokes to maintain the crowd's interest. The mortality rates associated with specific pre-anesthesia surgical procedures reveal the true cost of operating. Without effective pain relief, amputations, despite being among the most commonly performed surgeries, still carried mortality rates of 40 to 60%. Many patients died not from the surgery itself, but from the shock of experiencing such extreme pain while fully conscious. Abdominal surgeries were so rarely performed that they were considered experimental procedures well into the 19th century. The few attempts at operations like appendectomies or bowel resections resulted in mortality rates approaching 100%. The combination of extreme pain, massive tissue trauma, and inevitable post-surgical infection made survival from major abdominal surgery virtually impossible. Even relatively minor procedures carried significant risks in the pre-anesthesia era. Tooth extractions, which today are considered routine outpatient procedures, sometimes resulted in serious complications or death. Patients would sometimes bite through their own tongues during dental procedures, or suffer heart attacks from the stress and pain of having teeth pulled without anesthesia. The psychological impact on surgical patients who survived their operations was profound and long-lasting. Many developed what we would now recognize as post-traumatic stress disorder, experiencing nightmares, flashbacks, and severe anxiety attacks triggered by medical situations. Some survivors became completely unable to tolerate any form of medical examination or treatment, even for minor conditions. The families of surgical patients also suffered psychological trauma from witnessing their loved ones' agony. Family members were sometimes asked to help hold patients down during procedures, forcing them to participate directly in their relatives' suffering. The sounds of surgical procedures, the screaming, the sawing of bone, the sizzling of cauterization, traumatized not just patients, but everyone present in the operating theater. The cultural attitudes towards surgical pain varied significantly across different societies and time periods, but most shared the common belief that pain was an inevitable and perhaps even beneficial part of the healing process. This philosophical acceptance of suffering as natural or divinely ordained created significant resistance to early attempts at pain relief. Even when effective methods began to emerge, religious authorities often opposed efforts to eliminate surgical pain, arguing that suffering was part of God's plan for humanity. Some Christian theologians specifically cited biblical passages about women suffering in childbirth as evidence that God intended humans to experience pain during medical procedures. This religious opposition to anesthesia persisted well into the 19th century and significantly delayed the widespread adoption of pain relief methods. Military surgery presented its own unique horrors in the pre-anesthesia era. Battlefield injuries often required immediate surgical intervention, but combat conditions made even basic surgical preparation impossible. Surgeons operated in tents, abandoned buildings, or sometimes in the open air, with minimal instruments and no time for careful technique. The sheer volume of casualties during major battles overwhelmed surgical resources and forced military surgeons to make horrific triage decisions. Soldiers with survivable injuries who could endure surgery without anesthesia were prioritized, while those whose injuries would require lengthy procedures were often left to die. The screaming of wounded soldiers undergoing amputation or other major surgery was a constant background sound in military hospitals, adding to the psychological trauma experienced by other patients awaiting their turn. The speed required for military surgery led to the development of assembly line techniques where multiple surgeons would work simultaneously on different patients, moving from one amputation to the next with minimal pause between procedures. The floors of military surgical areas were often slippery with blood, and surgeons worked in conditions that would be considered appalling even by the standards of butcher shops. Naval surgery presented additional challenges, as operations had to be performed on ships that might be pitching and rolling in heavy seas. Surgeons developed specialized techniques for operating under these conditions, including ways to brace patients against the ship's movement and methods for rapid surgery that could be completed between waves. The legendary naval surgeon William Beatty, who treated Admiral Nelson after the Battle of Trafalgar, became famous for his ability to perform successful amputations even in rough seas. The training of surgeons in the pre-anesthesia era was largely based on apprenticeship and observation rather than formal medical education. Young men who wanted to become surgeons would serve as assistants to established practitioners, learning primarily by watching procedures and occasionally being allowed to perform minor operations under supervision. This system meant that surgical knowledge was passed down through generations of practitioners, but it also perpetuated ineffective or dangerous techniques. The lack of scientific understanding about anatomy, physiology, and infection control meant that many surgical procedures were based more on tradition and superstition than on medical knowledge. Surgeons often relied on techniques that had been used for centuries, even when these methods were demonstrably ineffective or harmful. The resistance to change was particularly strong in surgical practice, where innovation was seen as dangerous experimentation that might cost lives. The economic aspects of pre-anesthesia surgery created additional barriers to effective treatment. Surgery was expensive and time-consuming, making it accessible primarily to the wealthy or to charity cases who agreed to serve as teaching subjects. Many people with surgical conditions simply went untreated, living with chronic pain and disability rather than risking the trauma and likely death associated with surgical intervention. The cost of surgical instruments, which had to be cut by skilled craftsmen, also limited the availability of surgical care. Many surgeons owned only a basic set of instruments and had to improvise tools for unusual procedures. The quality of surgical instruments varied widely, and inferior tools could significantly increase the risk of surgical complications or failure. The social status of surgeons in pre-anesthesia times was generally lower than that of physicians, who were considered more learned and genteel. Surgery was seen as a manual trade, similar to carpentry or blacksmithing, rather than as a learned profession. This lower social status meant that surgery often attracted practitioners who couldn't afford the extensive classical education required. To become physicians, however, successful surgeons could achieve considerable fame and wealth, particularly those who developed reputations for speed and skill. Robert Liston, despite his infamous surgical accidents, was highly sought after by patients who believed that his speed gave them the best chance of survival. Other notable pre-anesthesia surgeons included Dominique Jean Larrey, Napoleon's chief surgeon who could amputate a leg at the shoulder in less than 4 minutes, and John Hunter, whose anatomical studies revolutionized surgical understanding even though he continued to operate without anesthesia. The development of surgical specialization was limited by the constraints of operating without anesthesia. Complex procedures that required detailed anatomical knowledge and precise technique was simply impossible. When patients were writhing in agony and surgeries had to be completed in minutes. Most surgeons were generalists who performed whatever procedures their patients' conditions required. From simple wound repair to major amputations, the few surgical specialties that did emerge were typically those that could be performed relatively quickly. Military surgeons developed expertise in treating battle wounds and performing rapid amputations. Naval surgeons specialized in treating injuries common to sailors, such as falls from rigging or wounds from maritime accidents. Urban surgeons often developed expertise in treating injuries from street accidents or industrial mishaps. The geographic variations in surgical practice reflected different cultural attitudes toward pain, suffering, and medical intervention. In some cultures, surgical procedures were integrated into religious or spiritual practices, with shamans or priests performing operations as part of healing rituals. These procedures often incorporated elements designed to provide psychological comfort or spiritual preparation, even if they offered little in terms of physical pain relief. Traditional Chinese medicine developed sophisticated techniques for acupuncture anesthesia, using needle placement to reduce pain during surgical procedures. While these methods were not entirely effective for major surgery, they did provide some pain relief and allowed for more complex procedures than were possible in cultures without any form of anesthesia. Islamic medical practitioners in the medieval period developed some of the most advanced surgical techniques of their time, including detailed anatomical knowledge and sophisticated surgical instruments. However, they too operated without effective anesthesia and faced the same fundamental limitations as surgeons in other cultures. The role of women in pre-anesthesia. Surgery was complex and varied significantly across cultures and time periods. In many societies, women were excluded from formal surgical training and practice, but they often served as healers and performed minor surgical procedures in domestic settings. Midwives, in particular, developed expertise in dealing with obstetric emergencies and sometimes performed procedures that would be considered surgical by modern standards. Some women did achieve recognition as skilled surgeons despite social barriers. Trotta of Salerno, who practiced in the 11th century, was renowned for her surgical skills and wrote influential medical texts. However, women surgeons were rare and often faced significant prejudice and legal restrictions on their practice. Female patients faced particular challenges in the pre-anesthesia era, as cultural taboos about modesty and gender interactions often complicated surgical care. Women sometimes had to choose between preserving their modesty and receiving necessary surgical treatment, and many procedures that involved intimate parts of the body were either avoided entirely or performed under conditions that increased the risk of complications. The development of anatomical knowledge through dissection provided crucial advances in surgical understanding, but this knowledge came at a significant cost in terms of human suffering. The anatomical theaters where dissections were performed often doubled as surgical theaters, and medical students learned anatomy through observation of both dead bodies and living patients undergoing surgery. The shortage of cadavers for anatomical study led to the infamous practice of body snatching, where graves were robbed to provide fresh corpses for medical schools. This illegal trade in dead bodies created a parallel economy that sometimes extended to murder, as in the case of Burke and Hare in Edinburgh, who killed people to sell their bodies to anatomes. The connection between anatomical knowledge and surgical skill meant that surgeons who had access to cadavers for study often achieved better outcomes than those who learned primarily through trial and error on living patients. However, the knowledge gained from dissection was still limited by the lack of understanding about physiology and the function of organs and tissues. The preservation of anatomical specimens in the pre-anesthesia era created collections that served both educational and morbid curiosity purposes. Medical museums displayed diseased organs, unusual anatomical variations, and specimens showing the effects of various surgical procedures. These collections provided valuable learning resources for medical students, but also attracted paying visitors who came to see the gruesome displays as a form of entertainment. The artistic documentation of surgical procedures provided some of the most vivid records of pre-anesthesia surgery that survive today. Medical illustrators created detailed drawings and paintings showing surgical techniques, anatomical structures, and the effects of various diseases and injuries. These artistic works, while valuable for medical education, also capture the horror and brutality of surgery performed on conscious patients. The emergence of medical journalism and case studies provided another form of documentation that reveals the realities of pre-anesthesia surgery. Surgeons began publishing detailed accounts of their procedures, including descriptions of patient responses, surgical outcomes, and post-operative complications. These early medical journals provide invaluable insights into surgical practice before the advent of anesthesia. The development of surgical instruments in the pre-anesthesia era was driven primarily by the need for speed and effectiveness, rather than patient comfort. Instrument makers were skilled craftsmen who worked closely with surgeons to develop tools that could perform specific tasks as quickly and efficiently as possible. The resulting instruments were often works of art in terms of their craftsmanship, but they were designed for efficiency rather than minimizing patient trauma. The standardization of surgical instruments was limited by the free individual preferences of surgeons and the capabilities of local craftsmen. Each surgeon might have their own preferred designs for common instruments, and the quality and design of surgical tools varied significantly between different regions and time periods. The maintenance and care of surgical instruments was a significant concern in the pre-anesthesia era, as these tools were expensive and difficult to replace. Surgeons often personally maintained their instruments, sharpening blades and adjusting mechanisms to ensure optimal performance. However, the concept of sterilization was unknown, so instrument care focused on mechanical function rather than cleanliness. The transportation of surgical instruments presented challenges for surgeons who traveled to perform operations or who worked in military settings. Instrument cases were designed to protect delicate tools during transport while allowing quick access during surgical procedures. These cases became increasingly sophisticated over time, eventually evolving into the organized surgical kits used by modern surgeons. The economics of surgical practice in the pre-anesthesia era created significant barriers to both patient access and surgical innovation. The high cost of surgical instruments, the time required for procedures, and the significant risk of patient death made surgery an expensive and risky proposition for both patients and practitioners. Successful surgeons could achieve considerable wealth, particularly those who developed reputations for skill and speed. However, surgical practice was also highly risky from a financial standpoint, as unsuccessful operations could damage a surgeon's reputation and reduce their future income. The pressure to achieve successful outcomes sometimes led surgeons to avoid difficult cases or to use overly aggressive techniques that might produce quick results at the expense of long-term patient welfare. The insurance and legal aspects of surgical practice were minimal in the pre-anesthesia era, as the concept of medical malpractice was not well developed. Patients typically accepted the risks of surgery as unavoidable, and unsuccessful operations were generally attributed to the patient's condition rather than the surgeon's skill or technique. The charitable aspects of surgical care provided treatment for patients who couldn't afford private surgical fees, but this charity came at the cost of being used as teaching subjects in public surgical demonstrations. Charity patients had little choice in their treatment and often received care from less experienced surgeons or medical students learning surgical techniques. The international exchange of surgical knowledge was limited by communication and transportation barriers, but some transfer of techniques and innovations did occur through medical texts, traveling surgeons, and military campaigns. Surgical techniques developed in one region might eventually spread to other areas, though this process often took decades or centuries. The influence of war on surgical development was profound, as military conflicts provided large numbers of patients with similar types of injuries and created urgent needs for rapid, effective surgical techniques. Many advances in surgical speed and efficiency were developed in military settings and later adapted for civilian use. The role of chance and experimentation in surgical development meant that many advances occurred through trial and error rather than systematic research. Surgeons who achieved successful outcomes through innovative techniques might develop new standard procedures, while those whose experiments failed were quickly forgotten. The documentation and preservation of surgical Knowledge was limited by the lack of systematic record-keeping and the oral tradition that dominated surgical training. Many effective techniques were lost when skilled surgeons died without passing on their knowledge. While ineffective or harmful practices sometimes persisted for generations because they were part of established tradition, the transition period, leading up to the introduction of effective anesthesia, saw increasing experimentation with pain relief methods and growing recognition that surgical pain was a significant obstacle to medical progress. Some forward-thinking surgeons began to question whether the traditional acceptance of surgical pain was necessary or beneficial. The early experiments with ether, chloroform, and other anesthetic agents were often dangerous and unpredictable, but they represented the first systematic attempts to address the fundamental problem of surgical pain. These early pioneers faced significant skepticism and opposition from the medical establishment, religious authorities, and society in general. The first successful public demonstration of ether anesthesia by William Morton at Massachusetts General Hospital on October 16, 1846, marked the beginning of the end for the era of surgery without anesthesia. However, the adoption of anesthetic techniques was gradual and uneven, with many surgeons continuing to operate without anesthesia for years after effective methods became available. The resistance to anesthesia came from multiple sources, including concerns about the safety of anesthetic agents, religious objections to eliminating divinely ordained suffering, and professional conservatism among surgeons who were reluctant to change techniques that they had spent years perfecting. The social and cultural impact of anesthesia extended far beyond medicine, as the elimination of surgical pain challenged fundamental assumptions about the nature of suffering, healing, and human endurance. The introduction of anesthesia marked not just a medical revolution, but a philosophical and cultural transformation that changed humanity's relationship with pain and medical treatment. The legacy of pre-anesthesia surgery serves as a reminder of how far medical science has advanced and how much human suffering has been eliminated through scientific progress. The courage of patients who underwent surgery without anesthesia, the dedication of surgeons who persevered despite the limitations of their era, and the relentless human drive to reduce suffering and improve medical care all contributed to the eventual development of modern surgical practice. Today, as we take painless surgery for granted, it's worth remembering the countless individuals who endured unimaginable agony in the centuries before anesthesia became available. Their suffering was not in vain if it contributed to the knowledge and techniques that eventually made painless surgery possible. The history of pre-anesthesia surgery stands as both a testament to human endurance and a celebration of the scientific advances that have made such suffering unnecessary. The story of surgery before anesthesia is ultimately a story about the triumph of human knowledge and compassion over ignorance and suffering. It reminds us that medical progress is not inevitable, but requires the dedicated efforts of countless individuals who are willing to challenge established practices and seek better ways to heal human suffering. As we continue to advance medical science in the 21st century, the lessons learned from this dark chapter in medical history continue to guide our efforts to reduce pain, improve outcomes, and preserve human dignity in all medical encounters. The personal accounts left by patients who survived pre-anesthesia surgery provide some of the most haunting testimonies of human endurance ever recorded. Beyond Fanny Burney's mastectomy, we have the journal of Nathan Smith, a Civil War soldier, who underwent amputation of his right arm at the shoulder without anesthesia. Smith wrote, "The surgeon commenced his work with what seemed to be a butcher's knife. I bit clean through the leather strap they had given me, and I am told my screams could be heard 3/10 away. I watched him cut through my flesh, then heard the grinding of the bone saw as he worked through my shoulder joint. I prayed for death, but consciousness persisted until the very last cut was made. These first-hand accounts reveal not just the physical agony, but the profound psychological violation that patients experienced. Many described feeling like they were being murdered rather than healed, a sentiment that speaks to the fundamental horror of having one's body mutilated while fully aware and helpless to resist. The development of restraint techniques became an art form in itself, with different surgical schools developing their own specialized methods for immobilizing patients. The Prussian method involved a complex system of leather straps and iron brackets that could secure a patient so thoroughly that movement was virtually impossible. The French preferred a technique that used multiple assistants positioned at specific points on the patient's body, each responsible for controlling different muscle groups. Some surgical theaters employed professional patient holders, who made their living by restraining surgical patients. These men, often former soldiers or laborers, developed incredible strength and stamina that allowed them to maintain their grip on struggling patients throughout even lengthy procedures. The best patient holders were highly valued and well compensated, as their skills could mean the difference between surgical success and catastrophic failure. The psychological profile of surgeons who could perform these procedures reveals fascinating insights into human adaptation to extreme circumstances. Many successful pre-anesthesia surgeons developed what we might now recognize as dissociative coping mechanisms, mentally separating themselves from the human suffering they were causing in order to focus on the technical aspects of their work. Dr. Valentine Mott, one of America's most renowned pre-anesthesia surgeons, was known for his ability to remain completely calm and focused while his patients screamed and writhed on the operating table. Colleagues described him as entering an almost trance-like state during surgery, moving with mechanical precision while apparently oblivious to the chaos around him. This psychological detachment was likely essential for surgical success, but it came at a personal cost that many surgeons struggled with. Throughout their careers, the selection criteria for surgical patients in the pre-anesthesia era were brutal. In their practicality, surgeons learned to assess not just the medical necessity of a procedure, but the patient's likely ability to survive the psychological and physical trauma of conscious surgery. Young, healthy patients with strong constitutions were preferred, while elderly, weak, or psychologically fragile individuals were often deemed unsuitable for surgery regardless of their medical needs. Children presented particular challenges for pre-anesthesia surgeons. While their smaller size made some procedures technically easier, their inability to understand or cooperate with surgical procedures created additional complications. Pediatric surgery often required even more restraints and assistance than adult procedures, and the psychological trauma inflicted on children who underwent conscious surgery was recognized even by the medical practitioners of the time as being particularly severe. The seasonal patterns of surgical practice reflected both practical and superstitious considerations. Many surgeons avoided performing elective procedures during the summer months, when heat and humidity increased the risk of infection and made surgical conditions more uncomfortable for both patients and practitioners. Winter surgery carried its own risks, as cold operating theaters could cause patients to go into shock more quickly, but the reduced risk of infection made winter the preferred season for major procedures. The lunar calendar also influenced surgical timing, with many practitioners believing that certain phases of the moon were more favorable for surgical procedures. While these beliefs had no scientific basis, they were taken seriously by both surgeons and patients, and surgical schedules were often planned around astronomical events. The role of alcohol in pre-anesthesia surgery extended beyond simple pain relief to become a complex ritual that served multiple psychological and social functions. The stirrup cup, a final drink offered to patients before surgery, became bisplacer, a traditional ceremony that marked the transition from normal life to the ordeal of surgery. Some surgeons developed elaborate pre-surgical drinking rituals, believing that the ceremony itself provided psychological comfort, even when the alcohol's pharmacological effects were insufficient. The quality and type of alcohol used varied significantly, based on the patient's social status and the surgeon's resources. Wealthy patients might be offered fine brandy or imported wine, while charity cases received whatever cheap spirits were available. Some surgeons developed their own special mixtures, combining alcohol with herbs or other substances believed to enhance its anesthetic properties. The aftermath of alcohol-assisted surgery often created additional complications, as patients recovering from both surgical trauma and alcohol intoxication faced increased risks of nausea, delirium, and respiratory problems. Many patients who survived the surgical procedure itself died during the recovery period from complications related to excessive alcohol consumption. The development of surgical speed as a specialized skill led to the creation of informal competitions and demonstrations where surgeons would showcase their ability to perform rapid procedures. These events, while serving some educational purpose, also reflected the peculiar celebrity culture that developed around successful pre-anesthesia surgeons. Robert Liston's legendary speed was not just a matter of surgical efficiency, but became part of his professional identity and marketing appeal. Patients specifically sought him out because of his reputation for rapid surgery, believing that his speed gave them the best chance of survival. This created a perverse incentive structure where surgical success was measured primarily by completion time rather than patient outcomes or long-term recovery. The timing methods used to measure surgical speed were primitive but standardized. Within the surgical community, pocket watches were used to time procedures, and surgical students often served as official timekeepers during operations. These timing records were kept and compared, creating informal league tables of surgical speed that influenced professional reputations and patient referrals. The international variations in surgical technique reflected different cultural attitudes toward pain, healing, and medical intervention. Islamic surgeons in medieval Spain developed sophisticated techniques for rapid surgery that influenced European practice for centuries. Their emphasis on sharp, well-maintained instruments and precise anatomical knowledge allowed for faster, more effective procedures even without anesthesia. Chinese traditional medicine developed acupuncture techniques that could provide limited pain relief during minor surgical procedures. While these methods were insufficient for major surgery, they represented one of the few systematic approaches to surgical pain management that predated Western anesthesia. The integration of acupuncture with surgical practice created unique, hybrid techniques that were more effective than either approach alone. Indigenous surgical practices in various cultures developed their own solutions to the problem of surgical pain. Some Native American tribes used ceremonial techniques involving rhythmic chanting, drumming, and psychological preparation that could induce trance-like states in surgical patients. While these methods didn't eliminate pain, they provided significant psychological support and may have activated endogenous pain-relieving mechanisms The role of superstition and magical thinking in pre-anesthesia surgery reflected the desperate human need to find meaning and control in situations of extreme helplessness. Surgical amulets, protective charms, and ritual preparations served important psychological functions even when they had no medical efficacy. Many surgeons developed personal superstitions and ritual behaviors that they believed influenced surgical outcomes. Some insisted on using particular instruments for specific procedures, while others developed elaborate pre-surgical preparation routines that had to be followed exactly. These rituals provided psychological comfort to practitioners who were operating under extreme stress and uncertainty. The patient's family and social network played crucial roles in pre-anesthesia, surgical preparation, and recovery. Family members were often required to help restrain patients during procedures, creating shared trauma that affected entire families. The psychological burden of participating in a loved one's surgical ordeal was recognized as significant, and many families struggled with guilt and trauma long after successful surgical outcomes. The social aftermath of surviving major surgery without anesthesia created lasting changes in family dynamics and community relationships. Survivors often became local celebrities or objects of morbid curiosity, with their surgical scars serving as permanent reminders of their ordeal. Some patients found that their survival enhanced their social status and reputation for toughness, while others became social outcasts due to the disabilities or disfigurements resulting from their procedures. The evolution of surgical instruments reflected the ongoing tension between effectiveness and humanity in pre-anesthesia practice. Instrument makers worked to develop tools that could perform necessary functions as quickly as possible, while minimizing tissue damage and bleeding. The resulting designs were often beautiful works of craftsmanship that reflected both functional necessity and aesthetic considerations. The personalization of surgical instruments became an important aspect of surgical practice, with successful surgeons commissioning custom tools designed for their specific techniques and preferences. These personalized instruments were often works of art, engraved with the surgeon's name or family crest and crafted from the finest materials available. The inheritance of surgical instruments created professional dynasties where surgical knowledge and tools were passed down through families. Sons who followed their fathers into surgical practice often inherited not just instruments but entire practices, including patient relationships and professional reputations built over generations. The maintenance and sharpening of surgical instruments required specialized skills that were often provided by the same craftsmen who created the tools originally. Surgeons developed close relationships with their instrument makers, who understood the specific requirements of different surgical techniques and could modify or repair tools as needed. The transportation of surgical instruments for traveling surgeons or military practitioners led to the development of specialized carrying cases and portable surgical kits. These cases had to protect delicate instruments while allowing rapid access during emergencies. The evolution of surgical kits reflected changing surgical practices and the ongoing refinement of surgical techniques. The economic impact of pre-anesthesia surgery extended far beyond the direct costs of surgical procedures to include the broader social and economic consequences of surgical disability and death. Families who lost primary wage earners to surgical complications faced economic devastation, while communities lost valuable, skilled workers and taxpayers. The development of surgical insurance and mutual aid societies reflected growing recognition of the economic risks associated with surgical procedures. These early insurance schemes provided financial support for families affected by surgical outcomes. Though coverage was limited and benefits were often insufficient to address the full economic impact of surgical complications, the apprenticeship system for training surgeons created its own economic structure, with aspiring surgeons paying substantial fees to established practitioners for the privilege of observing and assisting with surgical procedures. This system ensured that surgical knowledge was transmitted to new generations, but it also limited access to surgical training to those who could afford the associated costs. The guild system that governed surgical practice in many European cities created professional monopolies that controlled both the practice of surgery and the training of new surgeons. These guilds established standards for surgical competence and ethical behavior, but they also limited competition and innovation within the surgical profession. The relationship between surgical practice and social class was complex and varied significantly across different cultures and time periods. In some societies, surgery was considered a lower-class occupation suitable only for those who couldn't afford the education required to become physicians. In others, successful surgeons achieved high social status and considerable wealth. The emergence of surgical specialization was limited by the constraints of operating without anesthesia, but some areas of specialized practice did develop. Military surgeons, naval surgeons, and surgeons who specialized in particular types of procedures began to emerge as distinct professional categories with their own training requirements and practice standards. The documentation of surgical outcomes in the pre-anesthesia era was limited by the lack of systematic record-keeping and the oral tradition that dominated medical practice. However, some surgeons did maintain detailed records of their procedures, creating valuable historical documents that provide insights into surgical practice and outcomes. The development of medical illustration and anatomical art provided crucial support for surgical education and practice. Detailed drawings and paintings of surgical procedures, anatomical structures, and pathological conditions served as teaching tools and reference materials for surgeons who had limited access to direct observation of surgical techniques. The role of chance and serendipity in surgical development meant that many important advances occurred through accidental discoveries or unexpected observations. Surgeons who were alert to unusual outcomes or unexpected results sometimes developed new techniques that improved surgical success rates. The preservation of anatomical specimens and surgical artifacts created collections that served both educational and historical purposes. Medical museums displayed preserved organs, surgical instruments, and documentation of unusual cases, providing resources for medical education while also serving as repositories of surgical history. The international exchange of surgical knowledge was facilitated by traveling surgeons, military campaigns, and the gradual development of medical literature. Techniques developed in one region slowly spread to other areas, though this process was often slow and incomplete due to communication and transportation limitations. The impact of religious and philosophical beliefs on surgical practice varied significantly across cultures, but consistently influenced attitudes toward pain, suffering, and medical intervention. Some religious traditions viewed surgical pain as purifying or spiritually beneficial, while others developed techniques for minimizing suffering that were compatible with religious teachings. The transformation from the blood-sucked operating theaters of the past to the sterile, silent surgical suites of today represents one of humanity's greatest achievements in reducing suffering and improving the quality of human life. This transformation was made possible by the courage of pioneers who dared to challenge the status quo. the suffering of countless patients whose agony motivated continued efforts to find better solutions, and the gradual accumulation of scientific knowledge that eventually made painless surgery not just possible, but routine. The first successful demonstration of ether anesthesia by William Morton on October 16, 1846, didn't immediately end the era of conscious surgery. Many surgeons remained skeptical of anesthetic techniques, viewing them as dangerous innovations that interfered with natural healing processes. The adoption of anesthesia was gradual and uneven, with some practitioners continuing to operate without pain. Relief for decades after effective anesthetic methods became available. The resistance to anesthesia came from multiple sources and reflected deep-seated beliefs about the nature of pain, healing, and medical practice. Religious authorities argued that eliminating surgical pain interfered with divine will, while some medical practitioners worried that anesthetic agents were more dangerous than the pain they were designed to prevent. Professional conservatism also played a role, as surgeons who had spent years perfecting rapid surgical techniques were reluctant to abandon methods that had brought them success and reputation. The social and cultural impact of anesthesia extended far beyond medicine to challenge fundamental assumptions about human endurance, the nature of suffering, and the goals of medical treatment. The elimination of surgical pain represented not just a technical advance, but a philosophical revolution that changed humanity's relationship with medical care and physical suffering. The ethical implications of anesthesia raised new questions about medical practice and patient rights. For the first time in human history, doctors had the ability to perform complex procedures on unconscious patients who were completely unable to participate in or consent to their treatment. This new power relationship between doctor and patient created ethical dilemmas that continue to influence medical practice today. The legacy of pre-anesthesia surgery serves as both a reminder of how far medical science has advanced and a warning about the importance of continued progress in reducing human suffering. The courage of patients who underwent surgery without anesthesia, the dedication of surgeons who persevered despite the limitations of their era, and the relentless human drive to improve medical care all contributed to the eventual development of modern surgical practice. As we conclude this journey through one of medicine's darkest chapters, we are left with profound appreciation for the advances that have made modern surgery possible and a renewed commitment to continued progress in reducing human suffering wherever it may be found. The era of surgery without anesthesia is now, thankfully, relegated to history, but its lessons continue to inform and inspire our ongoing efforts to heal, to comfort, and to preserve the dignity of every human being who seeks medical care. The screams have finally fallen silent in our operating theaters, replaced by the quiet hum of modern medical equipment and the steady rhythm of mechanical ventilators. Where once there was agony, there is now peaceful unconsciousness. Where once there was terror, there is now trust. The transformation is complete, but the memory of what came before must never be forgotten, for it reminds us of the preciousness of the gift we have inherited, and our responsibility to continue building upon the foundation laid by those who suffered so that we might not have to.